About what we're going to be doing with our chest pain center and how that's going to impact certainly our local navigator in our hospital and how that's going to be planned for other hospitals. And so it'll be good time to talk about that, so feel free to interrupt me as we move on. So it turns out that this is sort of the season for capital approval, and we had our COO from Nashville travel to Tampa and review our request. And so we want to talk about what we're going to be adding to advanced cardiac imaging to get this program launched. And so this is the Memorial Hospital emergency room. It's a little blurry because it's been somewhat enlarged, but we're talking about our chest pain center there and how we're going to be co-triaging patients through the chest pain center with the ER group. And so basically we always start with traditional cardiology, and traditional cardiology, if you don't know it by now, you're going to know it soon because I speak about this quite often. And the traditional cardiology six-pack is a history and physical, EKG, echo, SPECT scan, and cardiac cath. SPECT scan and cardiac cath has gotten to be so coupled that it's called SPECT and cath now, SPECT and cath, because frequently the results of the SPECT scan are ignored, even though it's been done and has 22 millisieverts of radiation exposure. The results are ignored because of intuition and so forth, and patients are moved on to cardiac cath regardless of being positive or negative. And that turns out to be because there's 40% false positives. Blue Cross Blue Shield of Michigan study 47 hospitals, 65% false negatives, but it gets even worse. And of course, Memorial is about 50-50. That makes it a lot easier. 50% false positive, 50% false negative. University of South Florida has been 80% false positive. Ottawa, Canada, 9 hospitals, 88% false positive. And then you got all the false negatives. So basically it turns out we're cathing the wrong patients. And so we've got patients that don't have disease that are being cathed, and so we have 60% negative cardiac caths. And then we have patients that do have disease that are walking away and not getting the cardiac cath. And we presented quite a few of those here because they get referred for cardiac follow-up, and frequently by follow-up they do have coronary disease. And we reveal that to the surprise of the patient because they have a false sense of reassurance. And so there's also poor correlation with FFR, and FFR is putting a little catheter in the coronary and putting a wire across and pulling the wire back, injecting some adenosine, and looking at the pressure difference. And so it turns out that there's a poor correlation to that, and that's the bottom line according to the FAME-1 and FAME-2 study. So it also costs the system $7,000 if a cardiologist touches a patient, and so that's very expensive to our medical system. So we're looking at high cost, low value. And so how can we change this model? And you know, we've been moving towards trying to change this model, and co-triaging the emergency room is another way of our changing this model. So let's take a look at the current model. As patient presents to the ER, some of them are low risk, some are intermediate risk, and of course the high risk positive troponin patients are sorted out pretty rapidly. And we got troponin positive STEMI, and we got troponin positive non-STEMI. That's a very small percentage of patients. And then the third group is acute coronary insufficiency, and that makes up maybe 6 or 7%, maybe up to 10%, depending upon the center. And then we're left with all these other patients to sort out. Those patients are seen by the cardiologist perhaps at night if they're a busy cardiologist. They put them on for a SPECT scan the next day. The next day they get the SPECT scan, which you know is a 5-hour test. They get first the rest study, then they get the stress study. Usually the cardiologist will batch them, and you'll have maybe 5 or 6 patients lined up at the same time. And for our Lexa scan, the cardiologist comes through, hits them all. They all get their Lexa scanners, and then they line up for the SPECT scanner. SPECT scan taking quite a bit of time, maybe 45 minutes or so. And then patients are returned to the room, and then the cardiologist returns that night, reviews all the studies, and then decides what they're going to do with the patients. in terms of our hospital, since we don't have angioplasty and we don't have open heart surgery, patients get transferred the next day to another hospital. They may be on for cath that day, or they may be on for cath the next day, and so we got a prolonged, very laborious process that may involve 2 hospitals, and then 60% of these patients then have a negative cath, and they say, well, why did I go through all this? And so that's the big question, especially given the radiation exposure. And so we were interested in trying to show you how that's working and how we can change that. And so are there any comments up to this point? Any comments, anyone? Janet, do you have any comments? Okay, let's move on then and take a look at how we might be able to change this. And so we're talking about advanced cardiac imaging, value-based ER co-triage. Everything is switching to value-based. By 2018. It'll be at least 80% of Medicare and Medicaid will be value-based, which means we've got to be able to show decreased length of stay, improvement in chest pain, improvement in outcome, decreased readmission. So that's 30 days, decreased readmission at 90 days, decreased shortness of breath, and patient satisfaction. So this is our hand of cards, and we've been dealt this deck, and with this deck I've found that cardiac echo is invaluable, and actually if you have 100 patients with acute coronary insufficiency, the chances of having a negative wall motion study is less than 1%. Wow, that's pretty sensitive and very specific. Also, in terms of stress echo, we found that that's a very primitive process. It's been around for a long time, and it's lumped pretty much with SPECT scans in terms of false positive, very difficult to distinguish wall motion abnormalities, frequently have to use DEFINITY to be able to define the wall, and very difficult to basically distinguish false positives and false negatives. So that can be lumped into the SPECT scan and the same data. So we got SPECT scan fail. That took a long time to fail because we had to change the course of the procedure, and by changing the course of the procedure, we designed it to fail. And then we got the PET scan, was very expensive isotope that you have to order actually a generator for 42 days, and it costs $42,000. There's some pass-through in the isotope in terms of the cost, but actually the payers are paying in terms of Medicare the same as the SPECT scan. So it's more expensive, but the payer pays the same. You got to use a very expensive PET scanner. There's CT for attenuation correction. Some people have perfected this, like Dr. Lance Gould, who's in Houston. He spent $100 million in 43 years of his life. He's the father of coronary blood flow. He's the person who figured that coronary blood flow has to be reduced 85% before you can get acute coronary insufficiency or angina. And so he's done a very good job, and we send patients down there now because we can't in any way reproduce what he does unless we had a lot more expensive equipment. Right now, with what we have, which is kind of old, the isotope saturates the crystal too fast for us to be able to do very extensive coronary blood flow studies. So Dr. Gould has mastered that. So we just use Dr. Gould. Somebody gets on a plane, goes to Houston, Southwest Airlines, the hobby, takes a cab over to the Weatherhead Center at Herman Hospital, gets the attention of Dr. Gould. He does the test. He actually sits with the patient for 45 minutes after the test, going over the results, and then the patient flies home. That's not so bad when you consider the expense of all this isotope, the expense of the procedure, and the $100 million that's already been spent to develop the software. And then we got CMR, and we're going to talk about the sensitivity and specificity and how defined this has become, and then coronary CTA, which we discussed in the past, that there's a 50% reduction in fatal and non-fatal MIs if we do CT over standard of care, using the Scott study, continuation of study, which was reported at the American Heart Association meeting in 2015 and American College of Cardiology 2016. So this is a home run for us. So this is what we do that's different. We get to the echo and then we'll just bypass the SPECT scan, go directly to CT. The CT, actually, we've got a price point that's $329 now. So pretty affordable, reasonable price point. MRI is less than $500 now. And so those are not bad considering. And so you can see that here's our new price point. Here's our MRI price point. And then what happens downstream? Well, that's what the cost people want to know is, yeah, we've got high value, we've got low cost, but what about angioplasty and open heart surgery? Are we losing revenue? Well, yeah, you'd be losing revenue on the 60% negative CAS because we're going to reduce that number. But let's take a look and see what's happening with revenue in terms of angioplasty and open heart surgery, which are very important downstream directed revenue producers. So, well, 21% of the CAS are negative now, and so we dropped that from 60% to 21%, a significant drop in cardiac CAS. And then what are we left with? We're left with more patients for angioplasty because we've discovered this chronic total occlusions that we haven't discovered before. Well, what's going to happen with them? Well, we have to have people trained to do that. Right now, chronic total occlusions are being done by Dr. Lombardi, who is an expert at it and teaches all the classes. He travels around the world. He's in Seattle. We also have a Dr. Heuser, who's in Phoenix, who helps us with that. And now we've got help from the group in Emory, which is pretty easy. Again, you hop a plane, you're in Emory, spend the day there, get admitted, get the angioplasty done the next day, and come home either that night or the following day. So it's not a bad deal. And so we've got to train our own people to be able to do chronic total occlusions and do them easily without complications and without problems. That leaves open heart surgery, and actually open heart surgery increases. How are these things happening? Well, if we had the previous 65% false negative, then those patients had coronary artery disease. What happened to them? They went home. Well, now they're available for resolving their problems because they presented with chest pain and they do have problems. And so those would be the CTOs and the open heart surgery. Open heart surgery is on the decrease overall because of the ability to do chronic total occlusions. And so that's how the change is downstream. This is what all the administrators and CFOs want to know is what happens to the money. And so as our pilot project, as other pilot projects have already shown, this is what happens to the money. So value-based CP co-triage in the emergency room with the emergency room group has a protocol. And so let's look at what kind of protocol we have. Well, we do an NT-proBNP. Well, why don't we do a BNP? Well, BNP actually has a half-life of 22 minutes. So if you had some like flash pulmonary edema that was very brief, or elevated left ventricular end-diastolic pressure secondary to your angina, with a wall motion abnormality that was very brief, then the BNP will be negative. But the NT-proBNP stays positive for a long time. So it has a long half-life. So we like that. Troponin, we have various point-of-care troponins that we can use, and so that's not a problem. EKG, that's not a problem. We can repeat these tests in 90 minutes and get more information. Point of care is easy, EKG is easy. And then front-loading the echocardiogram, we thought about using a handheld V-scan. That's not very good for wall motion. It's a very primitive device and doesn't work. And so we got to have an echo machine in the ER. Can I use it? Yeah. Can my techs use it? Yeah. They may be on call. I may not want to call them in. Can my fellow use it? Yeah. You know, can some of our trainees use it in cardiac fellowship? All of them should be able to do that. And so it's a good skill to have. So, and then the patient is evaluated, and we have, how are we going to tell who's low and intermediate risk? Well, it's going to be based on history and on this information. And we're going to show you some more about our risk triage system. And so here's a little bit more to show you. And here we go. We've got Well, look at this. This is actually February 2006, and now presented again 10 years later in May 2016. So after we had someone admitted to the hospital who got under the radar, there was a lady who was admitted to a non-tele floor, medical floor, for what they thought was a gastroenteritis, when in fact she was having a cardiac event. She got by with having a left bundle branch block and having an acute MI that could be read with the left bundle branch block in his inferior wall, but the computer didn't read it because it's not programmed to read left bundle and acute MI, but it could be read 10 feet away looking at EKG because of ST segment elevation and upward coving in the inferior leads. So the patient got admitted to general medical floor and was being treated for gradually dropping blood pressure for gastroenteritis and dehydration, and it took till 2 in the morning that wasn't working, and the patient was going into shock from an inferior wall MI, and we couldn't rescue her. She got transferred, and it was a lot was done too late, and she died, unfortunately. And that gave us an opportunity at Memorial to review our protocols and discuss how someone could get under the radar and how we could prevent it. And so we focused, because of that, on females at the time, because those are the patients that are being admitted to general medical floor with these crazy symptoms of nausea and vomiting or shortness of breath or hypertension or hypotension or tachycardia or bradycardia, all these different kind of things, syncope, near syncope, palpitations, when in fact they're having a heart attack. Blunt chest trauma is a different kettle of fish, but we put that on there because you certainly can get myocardial contusion, which has been a pretty benign process in the patients that we've seen so far. And so to take these patients and also male patients who are presenting with a typical template chest pain, arm pain, back pain, neck pain. Also, some of those have nausea and vomiting as a presenting symptom, etiology unknown, and putting them into our troponin EKG 90 minutes apart, and BNP stat, which is our NT pro BNP, which is what we use now. This was 2006. Urine drug screen for chest pain, looking for cocaine. Strongly consider echocardiogram at the hair trigger, and stat entry into our system so that we can access it immediately. Stat entry of the EKGs, if we can figure out how to do that, how to bypass the current system and get them into the computer system so that we can access it through the GE Muse from remotely. So big problems on how we get these into the system quickly. But we have other ways of doing that, and we'll talk about those soon, other than just entering into our PAC system or our computer system. Patient stays in the ER until we make some decision, and this is not necessarily so anymore, because we may be able to make some decisions based on the first troponin and the EKG, and I'll talk about that in a minute. And then the results are interpreted, faxed to a cardiologist, or emailed, or iPhoned, or telecardiology, or some way gotten to a cardiologist if it's not in Muse, which is very important to get the information to a cardiologist because we get early cardiology involvement. And so that's pretty important if you have a cardiologist involved early on in the system. Well, I had a similar system that we worked in the emergency room at MacDill Air Force Base for 10 years, and we never missed a single patient, no lawsuits. All EKGs were faxed. All information was available. We didn't have front load echo available at that time, and anybody that we had any suspicions, we would transfer to Memorial for a quick transfer for further workup. And so we had a very successful system, co-triaging with the emergency room at MacDill Air Force Base Hospital when they had a hospital. So then we have these kind of treatment items to review, and we can repeat the troponin later after the patient gets to the cardiac floor. We can do a coronary CTI, we can do a dobutamine or Lexiscan CMR, and we'll talk about these choices soon. Or we can troponin negative, low risk, coronary CTA or dobutamine alexiscan CMR, or troponin positive, either ICU transfer, transfer to the cath lab, transfer to another hospital, whatever is necessary, depending upon what we think is going on. So any questions about this triage, we can defer for a minute because we're going to give you a little bit more information about it. So just hang on for a second and I'll see what we can do with that. And let's reduce this, and then let's bring this back up. And here we are. And so let's talk about our equipment needs and what we need to do to put this in place, and then we'll show you how we sort out high risk and low risk. And so this is what's happened over a period of 10 years to create an advanced cardiac imaging center from a pre-existing outpatient radiology diagnostic center. And so you can see it's taken a lot of time, a lot of thought to get where we are. But CT, we had to add on step and shoot to reduce the radiation. That was $75,000 to do that. We then, in the next iteration, added on iDose, which is a way of lowering the kV, which lowers the radiation exposure. But by doing that, we get noisy X-rays. So then we computer process the images and get rid of the noise and make a silk purse out of a sow's ear. So believe it or not, that's very successful. And believe it or not, there's a new iteration of that, which is down here, which is CTI-IMR, which we'll talk about as we move down. And so add MBIR, acquire a vital images workstation, which is, we added that stuff down here. And then the PET-CT, it cost us $50,000 to purchase a cart. Let's see, oh, we had to activate the computer, which everything is already in the computer. It was an old Sun computer, but we had to get the key to activate it for $50,000, make it so it can actually perform what we need to perform, and we can draw up the images, and then purchase a cart for putting the strontium generator in for generating rubidium, and then activate the key for post-processing computer, and then add a gate. Very expensive when you consider all the stuff we had to do. There was a third part of should we add a gate to the CT scanner for another $18,000, and we ran out of money and said, no, we're not going to add a gate to the CT scanner. But if we did, we could do calcium scoring as well. And then the isotope purchase, at first we were paying $30,000 for 30 days, and then I found out that the generator actually was good for 42 days. And so I couldn't get anybody to sign off on that from Cardinal. You need a nuclear pharmacist to sign off on that because it was FDA approved only for 30 days, but it was good for 42 days. So I couldn't get anybody to sign off, and so then I got the company that was making it, Bracco, to take it to the FDA and ask approval for 42 days, because we're paying $30,000 and it's only good for 30 days, but it really should be good for 42 days and we'll get more of our money worth. And so it did indeed, the FDA did establish that was true, and so we got it approved. And then of course Bracco raised the price to $42,000, and so we didn't really win on that. And then somebody decided that they were going to use the generator for 50 days. And so they used it for 50 days and bled strontium in some patients who went to Canada and then came back home. And when they crossed the border, they were hot. And because strontium has a long half-life, and so they were hot for a long time. And they detected one came from Sarasota and one came from Las Vegas. And there's a case of what happened in Las Vegas didn't stay in Las Vegas. It crossed the border to Canada and then crossed the border and got caught coming back. And so that shut down rubidium scanning for a period of about 2 years until the FDA could figure out a foolproof method of keeping people who were fools from using it for 50 or 60 days. And so, of course, the fools got chastised, and they said, we don't want any fools anymore, so let's make it a little harder for you to be able to do this and have a little more process. And so it took 2 years for them to decide how to do that. And so That gave us PET scan becoming very expensive. There's a new isotopes that's being developed for that, and we'll talk about that in a minute, and how we can use that. And then we do have patients we're sending to Houston. The CMR upgrade to 36 channels for $30,000. Post-processing software for $60,000, which just died on the computer after 2011. That gave us 5 years, and it's dead. And so we have to get a new workstation to post-process, and then purchase a cardiac coil, which we're going to do now. Finally, after all this time, we're actually going to get a cardiac coil, because the cardiac coil then was no better than the breast coil or the chest coil. And so we actually compared them and had the techs choose which image with the text blinded, and they chose the image from the chest coil. And so we didn't buy the $30,000 coil, but we need it now, because there is also something that comes along with it, which is called the navigator, that has to do with breath hold measurement and being able to turn on and turn off the MRI during breathing. And it's a rapid sequence process that gives us a navigation gate. And then we had to add a gate for an EKG. And then we had to activate the key for the sequences. And so you can see, at least $200,000 gets you in. Unfortunately, that's a very lot of money, and most community hospitals can't make that jump. I've come up with a plan where you can do this by pyramid stages, and you do layers, and you layer the bottom foundation, and that might cost you $60,000, and then you add another $30,000, and you keep doing it year over year as you increase your sophistication of CMR scanning. And so there's ways around everything. And then add the T1 Molly, which tells us more things. And so let's look at the new stuff that we will have to add, which we're adding now. And so, well, a new piece of equipment is going to be our workstation. And the old workstation Philips just isn't good enough, and that's died too. And so the new Vital Images is superb and makes handheld communication with doctors, iPads, patients, iPhones, any workstation or any computer becomes a workstation. And so this is going to be really very, very modern for us, and it'll help us a lot. And we don't have to go walking around with disk where we download something on a CD and then take it over to Workstation and upload it again. We don't have to handle the data. There's no delay in terms of doing all that stuff. You can also push things to the cloud. You can drop things from the cloud. And so we're very excited about being able to have this kind of system that's so sophisticated, that when we do our TAVRs and make our measurements and all the stuff that we need for TAVR, we'll be able to get the information from Largo pushed over to the cloud and then push it back to Largo so they can do their TAVR. The same thing with Northside, where we get the information from Northside and then push the information back from Northside, and then we post-process things here in Hyde Park. And then other Florida hospitals at HCA West will be able to push in Brandon, wherever, as they developed TAVR, they'll be able to push information in Bradenton, Blake, and so we'll be able to help them with their CT scan guided TAVR, as well as MRI guided TAVR, if that's the way they're going. And so this is telecardiology. This is the ability to work with multiple hospitals, and Dr. Morales has been a pioneer in doing that. And of course, our cardiac fellows have gone back and forth in their training, and so they've learned the utilization of this. And of course, they're required to have that information in 2020 as far as the merger of the osteopathic with the ACGME education process. They're going to have to make compliance with COCATS 4, which are the new guidelines for advanced cardiac imaging, and we'll show you how that's been integrated into the process. And so Philips 64 CT upgrade to model-based iterative reconstruction, which is called IMR, not to be confused with MRI. And basically, again, you turn down the KV and make these images with sub-millisievert radiation exposure, and you can see how noisy they are. This is standard reconstruction. Got to get rid of this noise. So we got this image, actually. We can show you this image, and it looks awful. It's very grainy. And then we can show you how this image goes into the magic computer that cost $250,000, goes through the magic computer and comes out looking beautiful. And so that's the whole point, is to be able to smooth this out and look at a coronary like this, and here's a lesion in the coronary, but it could be an artifact and would be called a lesion somewhere when it's possibly an artifact, when in fact we can see it's definitely a lesion and it's not calcified. There's calcification distal to it here, and it's a convergent divergent double cone, and it's almost a total occlusion, and it's probably a soft plaque, and probably has a heavy necrotic core and is about ready to occlude. And so you can see that this post-processing results in this particular effective radiation dose was 0.9 millisieverts. So we get in the sub-millisievert level of X-ray exposure. So we're moving into the X-ray exposure of a couple chest X-rays. And so that's going to change a lot of things that we do. That gives us a possibility of being able to do X-rays on people that are younger individuals with this model-based iterative reconstruction. Perhaps, as you know, there's a presumptive heart and lung law for first responders and law enforcement officials, and basically one of the caveats of that is on physical examination, you have to exclude the presence of heart or lung disease being TB, heart disease being coronary artery disease, usually can be cardiomyopathies. But you have to exclude that, and you can't exclude that from a physical examination. So they get a PA and lateral chest X-ray with your TB, so you might as well do a equivalent to a PA and lateral chest X-ray, coronary CTA with IMR, and show that there's no coronary calcification and there's no coronary artery disease without calcification. And so this makes it possible to screen people below the age of 40 and below the age of 45, which have been our standard screening age of cutoff in terms of men and women. So going back to radiation exposure, most of our procedures are involved in this kind of radiation, which is above background in Tampa being less than 3 millisieverts per year, background in Bartol being 5 millisieverts, background exposure in Denver being 5 millisieverts per year. We've been working underneath this line. That's our cutoff. We don't want to exceed the yearly background exposure of someone in Tampa. So we've been working down in here, and with prospective coronary CTA, we're down in this area, and then now we're into the range of 2 mammograms, and so with our new iterative reconstruction model-based, we'll be in the range of a few chest X-rays, and then we do something called a plaquogram, where we just look at a single plaque a year or 3 years later. If we identify an interesting plaque or a plaque of interest that we can monitor for regression of heart disease, or at least conversion to less vulnerable plaques, we can use radiation exposure of that of a dental X-ray. And so, and the analogy doesn't just stop there. We're actually looking, just like the dentist does, looking for cavities and comparing Mr. Happy Tooth from before to Mr. Poor Tooth now. You know, we can make the same comparisons, hopefully Mr. Poor coronary artery to Mr. Happy coronary artery, so we'll see. We also will be implementing CT-FFR, and HeartFlow has been refining their technique of taking a CT scan, normal CT scan that you do, not a normal finding, but normal application of the technology, and then taking these images and using subvoxel evaluations and changes are able to make a clearer image, and then are able to do segmentation and then do 3D mesh. All of this is pretty standard software, and then quantification of rest coronary flow, and then microvascular resistance is calculated actually based on the myocardium and the thickness of the myocardium on the CT scan, and then a gradient is applied as if the patient received adenosine, and then the Navier-Stokes equations are applied millimeter by millimeter down each coronary artery with a supercomputer to finally then calculate what the FFR is across the coronary artery lesion. And so just like in the cath lab, you put a catheter in, and then you put a wire across, and then you pour the wire back after giving adenosine. This is, in fact, done the same thing with basically computer adenosine and CT imaged coronaries, and Navier-Stokes equations. And so this is shows that this is what this looks like, and this is the narrowing, and actually the narrowing was calculated at 67% of diameter, but this was not very distensible in terms of adenosine, and so the adenosine model does not hold this to be distensible and gives increased resistance, which results in a decreased FFR, which and in this patient ruptured in 4 days, and certainly with all this information should be considered for a stent, not because of the stenosis, because you usually have to have a stenosis of 85% before it's significant, but in this case the FFR is less than 0.80, which is highly significant, and so the FFR wins the day over diameter stenosis, which we all know that diameter stenosis in angiography actually places stents when you don't need stents 50% of the time, and when they don't need it, and the FFR now rules in the cath lab, even though it's used only 60%, only 6% of cases. You know, this also FFR is going to be ruling, and it's going to be much more convenient and a much faster process. So we'll have that information available to us, since HeartFlow has been running this software in major medical centers for the last year and a half as a trial, and has new FDA approval for a faster process, and is coming back to us to discuss how we can apply that. Here's some more FFRs on somebody with left main disease, as well as some LAD proximal disease and circumflex proximal disease being less than 0.80 makes this abnormal. This is actually a hypoplastic vessel, and this is dominant circumflex. So this one over here at 0.82 is of no meaning, because this vessel doesn't even supply the left ventricle. It's only a little vestigial vessel that's supplying the right ventricle. And so we've got a bunch of lesions in series resulting in severe disease. And so this is, again, a stenosis that's less than 85%. And you say, well, that's not going to cause any problems in terms of diameter, but we're underestimating the FFR, or overestimating, depending upon how you look at these numbers, of the FFR with the diameter stenosis. And then when we actually run it through the computer, because this is not going to dilate it because it's got a necrotic core to it, then the FFR is going to be lower, and that means that that lesion, being only 60%, is actually hemodynamically significant as if it were 85%. Upgrade for our MRI is something called T1 Molly, and T1 Molly gives us the capability of understanding and measuring fibrosis in the left ventricle, and that can be very diffuse and distributed diffusely. We can find it when it's scar tissue, but finding it when it's diffusely damaged from cardiomyopathies or infiltrative disease, it's much harder. So this is the sequence for measuring that, which we will have added to our MRI equipment. They're going to strip it down to just the magnet and then rebuild the entire MRI. And what you salvage is the magnet and the helium, which is very expensive. And then you just rebuild the platform, which is basically involves our getting a cardiac coil, which is much better now when you look at the coils, and our being able to then look at fibrosis. So actually this is somebody who has hypertrophic cardiomyopathy, which you know can be apically involved and can be also be septal, and but usually not lateral wall, usually not inferior wall, And we're looking at this particular ventricle, and we're looking at MOLY in terms of T1 uptake, looking at fibrosis, and we're seeing all this diffuse fibrosis in this left ventricle that you wouldn't have detected before. You would have just said that's heart muscle. And late gadolinium enhancement wouldn't have been present because it's not focal, but it's more diffuse, but it's local. So it's local and diffuse, not focal and dense. And so with that, now we can detect that with T1, which is time 1 relaxation MOLY, after challenging with the cardiac coil the magnetic field established over the heart. And so that's very pretty, and that has a lot of application with myocarditis and other diseases. And so then this is not what we use it for all the time, hypertrophic cardiomyopathy. It can warn us that this patient is at risk of sudden death, but it's a very classic example to be able to give you the strongest signal is from hypertrophic cardiomyopathy. So it gives us a chance to show you a very strong signal. Obviously, we'll get signals from sarcoidosis as the heart gets more fibrotic, or from cardiomyopathies. And so we also will have the breath navigator, which basically times breathing, so that for the first time we'll be able to get you really nice pictures of the origins of the coronary arteries. And actually you can see some coronary plaque. I don't think I gave you an example of plaque, but you can see some coronary plaque, and you'll be able to sort this out a lot better. This is the navigator and the coil that's part of that navigator system. And so we'll be able to have the software to identify coronary origins, identify coronary artery plaque, and do some more of our plaque studies that we've been working on so hard. And so here you go. And here's an anomalous right coronary artery with a subintimal course with a running between the aorta and the right ventricular outflow tract. And here's another coronary anomaly of the right coronary, the left coronary coming off the right and migrating over. And so we'll be able to discover these in athletes instead of having to do CT scans with radiation exposure in someone who's 20 years old. We'll be able to do a non-radiation exposure test. So we do have an interest, a strong interest in coronary anomalies, and we work with the Texas Heart Institute as part of a registry for coronary anomalies, and we're the local diagnostic center for the Southeast with our collaboration with the Texas Heart Institute to derive the coronary anomalies and to sort out those that are risky from those that are not risky at all. And that can be sometimes very testy, but very important to an athlete's future. Also gives us an opportunity for telecardiology, and this telemetry box that's frequently used, the camera and two-way video, is frequently used for neurology in a lot of hospitals, but it also has a stethoscope in there that can give you a tele-stethoscope, and there's also the ability to put the echo through here in the imaging chain and look at the echo, and of course converse with the patient and get some idea about what's going on with the patient in terms of them relating their own symptoms. And so this gives us an opportunity of combining the vulnerable plaque, low radiation plaque reading anatomically, and also combining that with patient being in the ER and drawing up images and encountering the ER doctor as well as the patient, and putting images through here as well as looking at the echo and EKGs. There's another part of the system that you can use if you so desire. You can get a system like Video. There are several companies that compete with this, and they have HIPAA secure space, and they have space that's also secure from hackers and ensured to be of medical quality, so that you can look on your handheld phone and come through this system, look at images, talk to people, just like you would be doing on the telecardiology, but using your handheld phone or your iPad. And of course, the most sophisticated system is the monitoring system that's being used. So you can upgrade from this little nothing handheld but very, very convenient thing to the most sophisticated observation of a patient in an ICU with EKG and monitoring data and monitoring maybe 10 patients at one time and being able to meet and talk to each one. And so the system expands from the very, very basic to extremely elaborate system. And this certainly would be interesting to the navigators because someday they'll be looped into this system very rapidly and be part of this. And so the next thing we're going to be doing is we'll be participating in another research study using fluoroperidaz, and that's the isotope for PET scanning that we don't have to spend $42,000 for a 40-day generator. We can actually spend just per dose unit that's flowing in just like everything else, made on a cyclotron, and basically has a couple-hour half-life and is delivered to us by unit dose. And so that makes it possible for us to sort out what in the past has been false positive nuclear scans. And so this is a comparison to show you how we generate false positive nuclear scans, how we generate false negative nuclear scans, and then how fluoroperidaz avoids that treacherous course that results in false positives and false negatives that are overwhelming. And so this is somebody that has attenuation of the inferior wall, and you can see normal coronaries. And so this is just in a male, would be the diaphragm or the stomach interfering during stress with the isotope transmitting its photon or a gamma ray at with technetium 140 keV and making these pictures that are fuzzy because of the range of the isotope and because of Compton scatter, and you see these images and you see the inferior wall and it looks like a reversible defect, but it's not, it's the stomach. And so you try to correct this by putting the patient prone. Doesn't correct it very much, but corrects it a little bit. And by trying some other things like getting them to drink some carbonated beverage that makes the stomach less dense because it's now full of CO2, and all the different shenanigans we've tried to get around this, but it's defeated us for sure. And you can take a look at this and look how nice and crisp the images are because of using a PET isotope, fluoroperidaz, which has a very short positron range before the positron meets an electron and is annihilated, and then gives out two photons that are 180 degrees apart, and they simultaneously will impact a circular detector, which will tell you that that's not scatter, it's two simultaneous emissions of photons as the positron annihilated with an electron. And so you get these really nice crisp pictures, and these are beautiful, and so I can't wait to start using this again. We were in the phase 2 study of fluoroperidaz, and now it's going to a clinical phase study that's actually beyond phase 3. And so we're excited about participating in that. And you can see, yeah, you can even see the papillary muscle here that you can't even see, at all because it's just blurred by the image. And there's a little papillary muscle there you can see that you can't see over here. And then you come over here, and this is our false negative, where basically here's our short axis images of stress, and here's rest. You say, well, is there something there? Well, I don't know. And of course the breast gets in the way, and we can't tell what's going on. Here's the stomach, at rest, and then we wonder, well, this is the breast coming across here, and so we're really kind of stuck. But then you come over here and look at these images, and these images are nice and crisp. Here's papillary muscle over here, here's papillary muscle over here, really beautiful, nice thin. And then here's the stress, where we basically have reversible defect of the anterior wall, apex, and septum. And we also have some RV uptake, which means it's a lot of myocardium involved if the RV is uptaking. And so this sort of clinches this one. So we want to bring this isotope back for beyond clinical phase 3 trial with the FDA and with Lantheus. And so that brings us to the end to our talk today about the upgraded equipment that we will be adding to our repertoire and how that's going to enhance advanced cardiac imaging and how we're going to be adding this to the emergency room, having an in-house CT, not just the out-house CT, not just the out-of-house CT that's in the diagnostic center, and then being able to put this in place. And we can show you that we actually have put together a risk score that's the Memorial Risk Score evaluator in place of GRACE, TIMI, and HEART scores and some of the other score systems that are very cumbersome. And our score system is basically these 5 facts. Do you have normal or a non-specific EKG? Do you have a normal wall motion? On the echo, it's not going to be the V-scan because it didn't work for us. We tried it. Do you have a family history of coronary heart disease early in life? Do you have a negative first troponin? Is there no classical angina template? And of course, no pre-existing history of coronary heart disease. And you add up the zeros, and who can't do that in your head? And so then you come up with a total score of 0, which immediately takes 80% of the patients with chest pain and classifies them as low or intermediate risk, and they can go on and get their scans. And so we'll be able to sort out this whole big gob of patients from the unstable angina, acute coronary insufficiency, STEMIs, and non-STEMIs. And see, we've got unstable anginas like 8%. So we got a total of like 12% usually of some kind of cardiac disease, stable angina, non-STEMIs, unstable angina, and STEMIs in this group here. So and with 47% not knowing what was wrong with them, even when they go home, we'll at least be able to tell them yes or no on coronary heart disease if we do CT scan. If we can't do a CT scan because of the heart rate, which we have new tricks for lowering the heart rate, then we do an MRI, which basically can be done with Lexiscan or with dobutamine. And if the patient's had caffeine, we can't use Lexiscan, so then we do dobutamine, and we got a rapid sequence with dobutamine that we can use. So do we have any other questions or any questions from anybody about how these upgrades are going to give us a new window into chest pain in the ER and a new opportunity to be much faster in our evaluation and much more specific and sensitive, delivering value care that means that for the same or less money, we will be able to basically give patients more exact, documented information about their disease and be able to then make them so that their outcomes are better and they have less symptoms. Questions? Well, thank you very much for coming, and we'll be telling you more about this exciting news as we move on. Thank you. Bye-bye. Have a good day.